Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. Everyone is touched by psychiatric conditions, either themselves or a loved one. Do not suffer in silence. With help, there is hope. Today on Healthy Minds. So these are, while not yet ready for prime time, the types of research initiatives that can have an impact in the not too distant future.
That's correct. I have so much hope and excitement that we've identified a new pathway, the glutamate pathway, that can have these rapid effects. This is the first time that I've seen a drug have rapid effects within hours. And that's really exciting. And also to have a new pathway, a different mechanism of action than our traditional serotonin reuptake inhibitors means that there's a whole new pathway of medications to explore that can be helpful for patients.
It's a game changer. It's a game changer. That's today on Healthy Minds. Healthy Minds is brought to you in part by the American Psychiatric Association Foundation, the Graham Beck Foundation, and the New York State Office of Mental Health. Welcome to Healthy Minds. I'm Dr. Jeff Borenstein. What exactly is obsessive compulsive disorder, OCD, and what is the treatment? Today I speak with a leading researcher, Dr. Carolyn Rodriguez. We discuss the symptoms and treatment of OCD, as well as new research advances which will help transform the treatment of OCD. Carolyn, welcome. Thank you for joining us today.
Thank you for having me.
I want you to tell us about OCD. People have heard of it, but what exactly does a person with OCD experience?
Obsessive compulsive disorder, or OCD, is characterized by two things: obsessions and compulsions. And obsessions are intrusive thoughts, images, or urges that increase anxiety, and compulsions are repetitive behaviors or mental acts that an individual is compelled to perform to decrease anxiety. OCD is common, and outside of the symptoms themselves, there's also deep private suffering that individuals have. I think that's one of the biggest misconceptions about obsessive compulsive disorder. People sometimes refer to it in a joking way as a personality quirk. But in fact, if people were to see the individuals that come and see us in our clinic, they would realize how much personal suffering and how serious these cases are.
Often it really gets in the way of people being able to function at their fullest level because of that suffering.
Exactly. And I want to share with you maybe 3 examples to highlight the impact that OCD can have in an individual's life. One case is of a young high school teacher. Her case and the others that I'll describe are disguised for patient privacy. And this high school teacher really struck me, her case, and motivated me to go into research in obsessive compulsive disorder. And one of the things that was most striking for her is that she needed to have everything ordered and arranged perfectly. And as you can imagine, a teacher at the end of the day, she would get stuck doing this over and over and over, and she was unable to get home to her family. She would just be literally stuck. Another case is an individual that came to see me last week, first time seeking treatment for OCD, and she had intrusive thoughts of contamination. And while her symptoms, typical of OCD, were waxing and waning, she ended up getting pregnant, and within days of bringing home her newborn home, she had so much overwhelming OCD and contamination with changing the diapers that she realized she wasn't able to care for her own child, and she ended up having to give her child up for adoption. It's a terrible choice that she had to make, but really profoundly impacted her life. And third, I want to highlight the case of a young programmer, freelance, works at home mostly, and again has these thoughts of contamination, but manifest a little bit differently in the sense that he felt the need to ritually bathe and wash in a certain way, brushing his teeth 3 to 7 times a day very vigorously to the point where his gums were bleeding. And it got to the point where eventually he just gave up entirely and didn't take care of his teeth. And he has now such poor dentition that his teeth need to be removed. So while not all the cases are that extreme, I want to highlight that this is something that can really have a big impact on somebody's life trajectory.
So if somebody's experiencing this, what should they do?
There are many people that suffer with this, and the first thing is reaching out for help. The second thing to know is that there are effective treatments. So the treatments that we have are both pharmacological. These are serotonin reuptake inhibitors, and these are things like Prozac and Zoloft. And there's also psychological treatments like cognitive behavioral therapy with exposure and response prevention. And both of these types of treatments are very effective for individual. Both alone or in combination have the potential to make around 50% of individuals with OCD well. So that's the great news.
Tell us a little bit about what happens with cognitive behavioral therapy for somebody with OCD.
It's a type of therapy in which you work carefully tailoring the treatment to the patient and to their fears. For example, if somebody has contamination fears, then the therapist would work with them to outline a hierarchy of things that are the least feared to the most feared. And the idea behind it is when you have an obsession, anxiety increases, and individuals do a compulsive behavior that they think decreases that anxiety. And what you do in exposure therapy is you keep exposing people to their greatest fear, their obsession, and you don't do the ritual, you don't do the compulsion. And so that anxiety, then, the more times you repeat it, gets lower and lower and lower. And that connection between having the distressing thought and having to do the behavior, that pairing is weakened.
Often people suffer for many years with OCD before actually seeking help. And there's a delay in that time frame. For many people, when do the first symptoms first appear?
So the symptoms appear in mid to late adolescence. Half of cases start by age 19, and a quarter of cases start by age 14. And it's very important to reach out for help at that point, because it can make a really big difference in somebody's life trajectory to get that care and that help.
What should a parent look for in their child if they think, how does a parent know that their child has OCD symptoms?
Mm-hmm. So OCD symptoms come in different types. One of the ones that most people are familiar with are contamination fears. So excessive hand washing, excessive hygiene is one. The other is fears of things not feeling quite right. So having to sit down a number of different ways until something feels right, having to pass through the doorway a certain number of times. And people internally experience that they need to have the right thought before going through a doorway, or they need to have the right feeling going through. And externally, a parent might see that as just, oh, they're joking around or they're going through something a lot of times, but that can be a clue. As well, repeated checking. So staying up later and later at night to make sure that things are turned off or checking the doors, that's one thing. So repetitive kinds of behaviors is certainly a clue. But some individuals have repetitive behaviors, these mental acts they do, where they don't have any overt symptoms.
It's just going on in their mind.
It's all in their mind. And so one individual I had a thought of the word David. It made him very anxious. And whenever he saw the word David, heard the word David, he needed to say John to himself, and that would sort of cancel out the anxiety about it. So nobody would ever know that this was going on. In addition, there are other things like reassurance seeking, making sure that things are okay, asking over and over and over. So those are some signs.
You spoke about the treatment and the cognitive behavioral therapy and medication. And the results of that. Tell us a little bit more about how that works.
One of the wonderful things, like I mentioned, is that serotonin reuptake inhibitors and cognitive behavioral therapy with exposure and response prevention can help either alone or in combination, 50% of people become well. However, there are a lot of people who don't get better. So the research that I do focuses on that other part of the population who either can't take serotonin reuptake inhibitors because of side effects. Side effects include sexual side effects, which a lot of people don't want to have, or other side effects in terms of dizziness or nausea in some cases. As well, with exposure and response prevention, we highlighted before that it can be scary, hard to do. And sometimes it's difficult to find a therapist in your area that is trained to deliver high quality exposure and response prevention. And so these obstacles then open up new areas of need. And similarly, both of those, in terms of serotonin reuptake inhibitors and cognitive behavioral therapy, take many months to take effect. So they take 2 to 3 months for clinically meaningful benefit. And so the work that I'm doing is to try and help identify new medications that have rapid action and can help patients with their symptoms.
Tell us a little bit more about that research that you're doing.
So while we don't know the causes of OCD, psychiatric disorders are increasingly thought of as circuits gone awry. And what we do know in terms of obsessive compulsive disorder and its associations, we know that there's hyperactivity of a thought control circuit. And this thought control circuit comprises 3 different areas of the brain. First is the cortex, the orbital frontal cortex. This is a front region of the brain that's important for planning and decision making. And then deeper structures in the brain called the striatum that are important for motor behaviors. And then finally the thalamus, which is a deep structure that is a relay center for this information back to the cortex. And so in OCD, this loop is hyperactive. And this loop and hyperactivity is thought to be associated with a chemical messenger called glutamate. And other chemical messengers are involved as well. But glutamate is the one that has the greatest convergence of evidence from both animal and human studies. And what I discovered is that a drug called ketamine, which changes the levels of glutamate, can have rapid decreases in OCD symptoms in the matter of hours. And it's very exciting for our patients, that discovery.
So your work is on a medicine that really has a different effect, a different mode of action, and has the potential to help a lot of people, and in a different way, with a rapid response, so people get better within a few hours instead of within a few weeks.
That's correct. We did a randomized clinical study. So randomized means that we have individuals either get ketamine or saline, so one thing that is an active and one that is a placebo. And we asked the question, how do the symptoms change over time when we give a single infusion of either ketamine or saline? And what we found in a small proof of concept study is for 15 individuals with obsessive compulsive disorder, those 7 that were randomized to saline, their OCD symptoms remained elevated. However, those that got randomized to ketamine had a rapid decrease within hours with the medication. And even long past ketamine was metabolized and outside of the body, it persisted having these effects and really reducing OCD symptoms. And in fact, 50% of individuals in that study had clinically meaningful reduction in their symptoms up to 1 week. And this was novel and exciting in several ways. One, as you mentioned, that patients were not on any other medication. They were not on the serotonin reuptake inhibitors like Prozac and Zoloft. So it's really the first drug that acts through a different mechanism, through the glutamate system. And it also has rapid effects within hours as opposed to serotonin reuptake inhibitors, which is 2 to 3 months.
People who are watching this who may not have responded, they may be in the 50% who don't fully respond to current medications, to cognitive behavioral therapy, are saying, hey, how do I sign up for this? But this isn't yet ready for prime time, so to speak. Tell us a little bit about where the research is going.
So while ketamine is a very exciting and promising treatment, it has some downsides. One is that it has side effects. So the side effects can include dissociation, a feeling of unreality, a feeling of floating and euphoria. People can't drive for 24 hours after getting a single infusion. It can also cause nausea and headaches in some individuals. And so as a clinician, would never want to give somebody a medication that would with that side effect profile. Although patients themselves are, when they weigh the pros and cons, having something that really impacts their lives is very promising. And then as well, the ketamine, what we know is that while 50% of individuals have treatment remission up to 50%, we don't yet know how long that lasts. And looking at other literature, ketamine's effects wane after time. And so the next clinical direction would be repeated dosing of ketamine. However, great caution needs to be taken in looking at repeated dosing of ketamine because we don't yet know all of the evidence out there and how it may impact the brain to have repeated doses of ketamine.
And now I know you've also been doing work on medicines that may have similar actions of ketamine, perhaps without the side effect profile. I'd like you to tell us a little bit about that.
One of the questions then, because ketamine, we don't know how long it lasts, and in terms of the side effects, we wanted to try and identify if there was a compound that could act in the same way as ketamine, using what we understand about the glutamate pathway, but not have those side effects. That would be something as a clinician I could get very excited about. And what we found was there was a compound called rapastanel, which had been studied in animal models and had antidepressant-like effects without ketamine-like side effects in animal models, which then the next round of studies was in humans with major depression. And again, it showed these decrease in depression without the side effects. And so the question that we wanted to ask was, will it have these similar effects on obsessive compulsive disorder? And so we did a very small proof of concept study in which we gave 7 individuals IV rapastanel, a 3 to 5 minute infusion, and looked at their symptoms over time. And what we found is that there was rapid decrease within 90 minutes of obsessive compulsive symptoms, anxiety, and depression. And it didn't have the side effects that I had seen in ketamine. No dissociative side effects. It was very well tolerated. We were very excited because it had this decrease in obsessive compulsive symptoms, anxiety, and depression very rapidly within 90 minutes. And that, paired with the fact that it didn't have any of the side effects that I had seen with ketamine, so no dissociation, no nausea, no headache, remarkably well tolerated for our patients, was quite exciting to me. Now, the next step for the research is trying to understand how frequently the dosing needs to be. Because unlike ketamine, which the effects lasted up to 1 week in 50% of individuals, rapastanel didn't have those longer lasting effects, meaning that it needs to be dosed more frequently.
And that's something that that's the next step of investigation.
That's the next step in this line of investigation, that's correct.
So these are, while not yet ready for prime time, the types of research initiatives that can have an impact in the not too distant future for many people.
That's correct. I have so much hope and excitement that we've identified a new pathway, the glutamate pathway, that can have these rapid effects. This is the first time that I've seen a drug have rapid effects within hours. And that's really exciting. And also to have a new pathway, a different mechanism of action than our traditional serotonin reuptake inhibitors, means that there's a whole new pathway of medications to explore that can be helpful for patients.
It's a game changer. It's a game changer, because if you think about it, with the current medicines that are often effective, waiting 2 to 4 to 6 weeks is difficult, whereas waiting 2 to 4 hours to get an effect. And if somebody's suicidal and at risk of hurting themselves, having that suicidal risk lift right away and have them be able to go home safely and continue treatment on an outpatient basis and not interrupt their life is a game changer for so many people.
I think so. I'm very excited about that. I'm excited about the future. New directions include having that rapid effect, but then pairing it with exposure and response prevention. So I think we've traditionally thought of medications or therapy or together, but having something that really decreases somebody's symptoms can lower the barrier for entry for exposure and response prevention. And we talked in the beginning about how a lot of people are scared to do exposure and response prevention. So imagine a drug that could lower that barrier, and then you could get the synergistic benefits of both rapid action and the exposure and response prevention. It would be terrific. And in fact, we've assayed whether a single infusion of ketamine paired with 2 weeks of intensive exposure and response prevention can be of benefit to individuals. And our thinking is that ketamine increases in animal models brain-derived neurotrophic factor, which is important in facilitating extinction learning, learning and memory. And in the rodent models, 2 weeks is the time period in which it exerts these effects. And so we thought by pairing them during that critical window of time for learning and memory, we might be able to get synergistic effects. And in fact, we did. By 2 weeks, we were able to get 60% of individuals better.
So the initial dose of medicine that helps relieve the symptoms but by itself wouldn't last, paired with the cognitive behavioral therapy approach, really gets people better.
Exactly. And what I'm excited about with that approach is that exposure and response prevention, again, typically takes 2 to 3 months. And so by pairing both together, we can get 60% of people better in 2 weeks.
In many ways, research is a collaboration between the researcher and the people who are involved in the research, the patients. I'd like you to speak about that.
Definitely, I would be glad to. This is something I feel like participants in clinical research are really the unsung heroes of the new treatments that patients who are currently taking today are the beneficiaries of. It takes a tremendous leap of faith to volunteer to be part of a research study and to partner with OCD researchers in investigating new treatments. And it's something that we take very seriously, protecting their health information. And that means at the same time, nobody can know their contribution. And so I just want to say thank you to all those patients who have really volunteered their time so selflessly.
Right, they're giving of themselves to help others down the road.
Right.
Often people with OCD have additional symptoms above and beyond the OCD. Obviously anxiety, but often depression comes along with it, and I'd like you to speak about that.
So individuals that have obsessive compulsive disorder, majority of them have comorbid conditions like depression. Some individuals can have suicidal thoughts. And we really want to try and intervene early for people that are suffering and in great pain. There's many treatments for obsessive compulsive disorder, for depression, that can be helpful. And reaching out and not suffering in silence is very important.
I want to ask you about a related set of symptoms that are referred to as hoarding.
Originally, obsessive compulsive disorder and hoarding disorder were thought to be one symptom. And recently, evidence has shown that these are actually two quite different disorders. While in OCD you have intrusive, repetitive thoughts, images, and urges that increase anxiety, and compulsive behaviors or mental acts that a person is driven to perform, hoarding disorder, on the other hand, you don't have these intrusive thoughts. People, on the other hand, are quite attached to their possessions, and they have difficulty parting with them. It causes them great distress. And these two things together lead to the accumulation of clutter in the home, where the rooms in the home are not able to be used as intended. And it comes with a lot of distress and suffering on the part of the individual.
The key commonality between OCD and hoarding is really the distress that people experience, often by themselves in silence, about this, the shame, the embarrassment, and as a result of that, lack of discussing it with anyone, seeking help for it.
I would second that, and I think that's why shows like this are very important.
Well, I appreciate that, and I'm saying thank you for the work that you do, helping patients clinically, one-on-one and in groups, and the research that you're doing to improve our ability to help people down the road. And certainly thank you very much for joining us today to share your experiences and your knowledge.
Thank you so much.
Thanks. Many people with OCD suffer in silence, often without seeking help. Current treatments, including medicine and talk therapy, are effective for many people, and new treatments are being developed. Do not suffer in silence. With help, there is hope. Until next time, I'm Dr. Jeff Borenstein. Goodbye. Do not suffer in silence. With help, there is hope. Healthy Minds is brought to you in part by the American Psychiatric Association Foundation, the Graham Beck Foundation, and the New York State Office of Mental Health. If you would like to watch our expert interview in its entirety, log on to bbrfoundation.org/healthyminds.